Okay, this next lecture series is going to be on surgical nursing, and it should be fairly quick. There's 3 chapters, but they're kind of short. So this starts in volume 1 of your textbook on page 400, and it gets done at page 460, and that encompasses 3 chapters. So I'm just going to hit the highlights. We've talked a lot about surgery, as we've talked about a lot of the medical surgical problems that med-surg nurses face. So this is just sort of an overview of actually what is the surgical experience. The entire thing is called the perioperative experience, but it's broken down into the preoperative, intra-op, and post-op. And so we're just going to point out, a couple things that you need to know about along the way. There are in the preoperative phase, you need to know the different kinds of surgeries. And by that I mean, is it ambulatory? Meaning, can the person walk in? And usually by ambulatory surgery, we mean outpatient surgery, meaning they're going home that day. Is it going to be an inpatient case where they have to stay overnight in the hospital? There are informed consents that have to be done. And this is kind of an important thing for the nurse, is that whoever is performing the procedure, that's the person that has to obtain the informed consent. So it's never appropriate for a nurse to obtain the informed consent, because the informed consent is a document that states this is the procedure that's going to be done, this is why it's going to be done, you understand the risks, you understand the benefits, and you're signing. Sometimes when this changes a little bit is in emergent situations. To preserve the life of the patient, it's okay to go ahead and perform the surgery without obtaining the informed consent to save the life of the patient. This is like your crash victims that come in, your patients that come in that are unconscious, but they're bleeding and hemorrhaging, and you have to get them to the surgery right away. Usually in situations like that, there are laws in place called the Good Samaritan laws, where you can't be sued or considered negligent because you were doing what was in the best interest of the patient. But typically when those situations occur in the hospital, then there's somebody, either a nurse manager or somebody else, that will attempt to find family members or get somebody else to be able to sign for the patient. Also with children, parents have to sign. Anybody under 18 has to have a parent or guardian sign. The other things you need to know about in the preoperative phase, typically if it's not an emergent situation, there are other kinds called urgent situations. This would be like your cancer patients. We've identified that there's a malignancy and we need to take it out quickly, but if we don't take it out like in the next 15 minutes, it's probably not going to be a big deal. Or there's elective surgeries, which are your plastic surgeries, your surgeries that it's not going to matter one way or another if the patient gets it tomorrow or in 6 months. And those are things like breast augmentation, tummy tucks, rhinoplasty, like nose jobs. Those things are elective surgeries. And even some of the more minor things, like I can't even think of some, but the urgent ones would be like removing malignancies, like the repair of a cystocele, repairs of rectoceles. I'm trying to think of some other stuff like orthopedic. Orthopedic ones are kind of urgent because you need to get those done quickly because the bone will start forming. So that needs to be done within a couple of days. It's not emergent unless there's hemorrhaging. Then it becomes an emergent surgery. So those are some things that have to take place preoperatively. It's important to teach the patient what to expect, what the surgery is going to be like. Let them ask any questions, try to alleviate their fears. It's a very scary thing to have to go into surgery, so you want to calm them down. Usually nursing diagnoses are risk for anxiety or actual anxiety related to unknown procedures, things like that. So answer questions, calm their fears down. That's a big nursing responsibility. Typically, also, if the patient is having an urgent or an elective kind of surgery, they have time to do some preoperative physicals. Usually you want to get a good good screening in, good lab work done, find out, because you don't want the person to be anemic. Your diabetic patients you need to be careful of, because preoperatively you need to figure out what their insulin is, because having surgery is going to alter their glucose levels. Okay, all right, come on. Okay, here. It would also alter their glucose levels, so you need, don't scratch that. You need to figure out what their glucose is going to be doing afterwards. People who are on steroids, oh, my cat is shedding. So annoying. People who are on steroids are at high risk for delayed wound healing, so you need to be careful with patients who are on steroids, and they may have to alter their steroids or go on a steroid taper. So those are some of the things that you would do preoperatively. And it's important preoperatively to focus on getting the patient ready for surgery, and you're not going to do things that are going to be better suited for the post-operative nurse. Like, for example, if your patient is going in for gastric bypass surgery, that would be considered an elective surgery. And obviously they're going to need to alter their lifestyle, their eating. We need to teach them about dumping syndrome and things like that. But that would be better suited for post-operatively. Pre-operatively, we're going to make sure they're healthy enough for surgery, and then we're going to focus on those things that they're going to do in the immediate post-operative phase, like coughing and deep breathing, getting up and walking and things like that. And then we're going to hope that our post-operative nurse on the floor or the post-operative nurse who's discharging the patient home is going to do the teaching that needs to occur at home. Because if you do the home teaching preoperatively, their anxiety is so high they're not going to retain any information. Okay, so that's kind of it with, another thing, when you're doing a preoperative assessment, there is this thing called malignant hyperthermia. It's not super common, and there's a genetic component to it, and there's certain medications that can contribute to it, which I'll talk about in the intraoperative phase, but you need to assess for it preoperatively. And the way that you do that is you ask your patient if they've had any family members that have gone into surgery and not had a good outcome. The problem is it is fatal. It's a fatal problem, but you don't want to say to somebody who's going into surgery, by the way, have you ever had anybody die in surgery? Because that's going to increase their anxiety. So you start asking like some leading questions. Because malignant hyperthermia, they're finding out there's a genetic component to it. And some people under certain kinds of anesthesia get crazy high temperatures and muscle rigidity, and it's fatal. So you need to screen for that ahead of time. So that's something that would be included in the preoperative phase. So kind of look through some of that. It tells you about informed consent, and you want your patient to stop smoking as much as possible. This is often really difficult, especially if their anxiety is high. So if they can at least have no cigarettes 24 hours before surgery would be good. Usually they have to be NPO. If they have a latex allergy, this becomes a bigger deal, and you need to find out about allergies preoperatively, because there's a ton of latex stuff in the operating room itself. And so typically if somebody has a latex allergy, it takes a couple days to get the surgical suite ready and latex free. So that's kind of it. You can read through the preoperative checklist, and then in the preoperative phase, after you prepare the patient, you're getting them ready for surgery, and then the patient goes into like a holding area or the preoperative area, at which time then they remove all the patient's clothing. They will remove all jewelry. You can't have jewelry on in surgery because they use a lot of cautery devices, and you don't want to create sparks or create more burns, so they remove all of the jewelry. And typically in the preoperative holding area, they will start IVs and make sure they have good IV access. And then they take the patient into the operating room when the operating room suite and the surgeon is ready for the patient. So once the patient goes into the operating suite, and some of you may end up wanting to work in the operating room, the operating room is typically cold because the cooler that it is, it keeps bacteria down. The main job for the operating room nurse is to control infection. It's a very sterile environment. So the circulating nurse is the one that controls infection and the spread of bacteria. So that person will, there's a special procedure to wash your hands. There's a special soap that you wash your hands, and then you'll see the surgeons and the nurses who are going to be working on the patient. They will hold their hands in this position because anything lower than the level of the waist is considered not sterile. So they hold their hands up like this. They put on the sterile gloves and gown, like I'm sure you guys have learned in Skills Lab. And then they create a sterile environment with sterile drapes on top of the patient wherever they're going to operate on the patient. And then all that has to remain very, very sterile. The circulating nurse is usually the RN in the operating room. That person is not sterile, but they're clean, meaning those people all have their hair up in nets. They wear masks. They wear covers on their feet. And they don't touch the sterile area, but they make sure that everybody who is sterile is only touching the sterile area. If they touch something that's not sterile, then they have to step away from the sterile area and re-glove. The other things that are important for nurses to know in the intraoperative area, inside the operating room, position matters. And it matters for that intraoperative nurse then to tell the PACU nurse, the post-operative care, and then for that person to tell the floor nurse, because position matters. If somebody is getting a pelvic surgery done and their feet are in stirrups and they're in the lithotomy position, especially if they're old, that can be very, very hard on the hips. They can have a lot of hip pain afterwards. And if they're sitting, if they're in lithotomy, that puts a lot of pressure back on the sacrum. And so the nurses need to be aware of pressure ulcers in the sacral area after surgery. If they're in Trendelenburg, like if they're doing a lap chole or something and they're in Trendelenburg, they can have headaches, they can have shoulder pain. If they get a spinal anesthesia, meaning, and this is the other thing, in intraoperatively, they can have different kinds of anesthesia. They can have spinal, where the patient's actually awake but they don't feel anything, like women who are giving birth and doing C-sections often get spinals or epidurals in their spine, so they don't feel anything but they're still awake. Spinal anesthesia can lead to headaches because of the loss of cerebrospinal fluid, drops the intracranial pressure and can cause headaches. If your patient has had that and they come up to either in the PACU, the post-anesthesia care unit, or the med-surg unit upstairs, and they're complaining of a headache following a spinal cord injury, you need to keep the room dark and quiet. This is not the time when a bunch of family members should come in. Make sure they have adequate fluids because you're wanting to get the fluid status up. You keep the head of the bed flat so that the cerebrospinal fluid is equalized. If a patient has had general anesthesia, this one puts the patient most at risk for pulmonary problems because a lot of those general anesthetics cause not pulmonary depression, muscular depression. So it's difficult to actually expand the lungs and get the carbon dioxide out. So it's really important to do that coughing and deep breathing. Also, when the patient is intraoperative, the patient can start getting cold because the room itself is cold, and usually then the skin has been broken because of surgery, and skin is a big heat retainer. So when that's open, especially in your big GI cases, your big pelvic cases, you've got that abdominal cavity open for long periods of time in a cold environment, and the patient can get very cold. So if you're working in the intraoperative area as the nurse, it's important to monitor temperature. If you are fearful that that patient is at high risk for hypothermia, like very thin or very elderly, frail people, you might want to include some warm fluids. You might want to make sure that the parts that are not being operated on have blankets on them before putting the sterile field on. The other things that you would do intraoperatively is you have to do counts, so you make sure that however many sponges go in, those same number come out. However many tools go in, like the hemostats and the scapulas and the cautery things, that however many is in there being used, you count them first and then you count them afterwards, because there have been cases where a sponge gets left inside a person, or a hemostat gets left inside a person. So they do counts. Also, what they do preoperatively, and this is in coordination with the intraoperative nurses, is that typically the patient will sign whatever limb is being operated on. So if they're having a knee replacement, they sign the knee, or they sign that, because also what's happened is they got in the operating room and the surgeon operates on the wrong limb or amputates the wrong limb, and as you can imagine, that's obviously devastating. So it's important to, one, identify the patient, identify what's being done, identify what part is being done, and coordinate with all steps of the perioperative phase so that to ensure that some of those errors don't occur. So that's really what happens in the intraoperative phase. So once the intraoperative phase is coming to a conclusion, some of you, if you're interested in becoming a CRNA, may end up working in this environment all the time, where you'll be the one actually doing the general anesthesia and making sure that the patient's hemodynamically stable while they are on general anesthetic, or whatever kind of anesthetic. It's general anesthetic, spinal anesthetic, local anesthetic. They can do some surgeries locally. Those don't usually have to be in the operating suite, and they can usually, a lot of those can just be done in the office. What else was I going to tell you? Oh, yeah, and so when they're doing general anesthetic, some of the medications that can also contribute to malignant hyperthermia are the things like like epinephrine. Succinylcholine is a big one that they use in general anesthesia. Other things like halothane can kind of contribute to it, especially in the presence of the genetic marker for malignant hyperthermia. Other narcotics like the morphines and just the spinals and the local anesthetics are not going to lead to malignant hyperthermia. Okay. What else was I going to tell you? I want to go back to the different kinds of anesthesia. Patients that have general anesthesia are at higher risk for pulmonary problems, just because I said like the decreased pulmonary functioning, because it's a neuromuscular depressor. So coughing and deep breathing, instead of spirometer after is big. Atelectasis is a big contributor to pneumonia, so you want to, if a patient starts spiking a fever post-operatively, if you can get them to coughing and deep breathing, oftentimes that will eliminate that, because it will eliminate atelectasis and a prevented pneumonia, which is really the goal. General anesthesia can cause nausea and vomiting, so you need to be careful. If you're working in the PACU, the post-anesthesia care unit, which is the holding period where somebody's going to be in there for anywhere between like an hour to 2 or 3 hours before they go up to the floor or before they go home. They'll be in the PACU, and that's when those nurses just make sure that the patient is waking up out of anesthesia, that they're you usually roll them on their side in case they do have emesis, so that they don't aspirate. You want to make sure that their pain is under control, make sure that they're urinating again, make sure that their vital signs are coming back into normal limits. Acid base can be a problem with your general anesthesia because you're retaining CO2 and you're not breathing as much, so you have to be careful to monitor their acid base balance. So then once the surgery is done, here's another thing. Your patients can also lose a lot of fluid. They can bleed a lot during surgery. And so afterwards in the PACU, they can have either hypertension because of pain or some vasoconstriction during surgery, or hypotension. So both are problems in the PACU that you have to watch for. General anesthesia can lead to dysrhythmias, so they should be on a cardiac monitor for a while following general anesthesia, just to make sure that their heart is not reacting unusually to general anesthetic. So those are some things you watch for in the post-operative phase. And then when you move into it's called the PACU, the post-anesthesia care unit, and up to the floor or home, that is the post-operative phase. And again, it depends on what phase they are. So early on, we're watching their heart. We're making sure they don't have nausea and vomiting. We're starting to watch for their pain. They're going to have pain. They've just had surgery, so you do have to make sure their pain is under control. We want them up walking as soon as possible, because they're at risk for DVTs if they're laying in one position. They're at risk for joint problems, depending on what kind of crazy position they've been in during the operation. So then the post-operative nurses, the PACU nurses don't necessarily have to worry about infection because that infection is not going to start for at least 24 hours. But the nurses who are working on the floor or the home nurses, now we're going to start watching that wound. So you're going to start assessing for fever Q4 hours. At least for the first 24 hours, it's Q4 hours. And then if it's pretty stable, you can go to QA. But you have to monitor for that fever to make sure they're not getting infection. The wound will probably have an incision on it for at least 24 hours, and then usually, depending on the kind of surgery, the surgeon is the one to take the first dressing off and put the new one on. But then after that, usually after 24 hours, then the nurses are responsible for changing the dressings. And during this time, you assess for that wound. Is it well approximated? Is it getting good granulation, meaning is it coming together? Are you teaching your patient how to splint, especially in your big GI cases, because you don't want those wounds to dehiss? And other things, I mean, it depends. Like if they've had eye surgery, we don't want them leaning over to increase the pressure in the eye or in the head. And then as they're getting ready to be closer to going home, then we start doing things like teaching them how to assess for their wound, teaching it, because usually if they have staples in, the staples usually stay in about 10 days, so they have to usually go back to the surgeon's office and have the staples removed, or the if they're getting a home nurse, the home healthcare nurse could come in and take the staples out. It kind of depends on what sort of surgery they're having done. And then this is when they do things like the teaching, like for your GI cases, like what is dumping syndrome? How do we prevent it? How do we do Kegel's exercises so we don't have a cystocele again? How do we, not wait there on our broken bone until the time where the surgeon says we can walk on it again. So it's those kinds of things we start doing before the patient goes home to ensure safety and continued healing when the patient gets home. And then what to do about it. Like if you get a fever, who do you call? If if you're not hungry or if you're getting constipated, constipation is a huge problem after surgery. So are you drinking enough water? Are you getting the fiber? Are you getting, are you up walking around so you're not developing ileiases? Those things, and narcotics will lead to paralytic ileiasis, causes constipation, so we want to get them off the narcotics as soon as possible. So can we switch them to Tylenol or ibuprofen within a couple days, and will that control their pain so they can get off the narcotics? So it's things like that become the post-operative nurse's job. So I think, as I'm looking through here, you can see, skim through these couple pages so you can see what I'm talking about, the different positions, different wound healing. There's some pumps following surgery. A lot of times the surgeon will put a pump in or a drain in if they think they're going to have a lot of excess serosanguinous fluid that they're going to want to drain. So the postoperative nurse is going to need to be responsible for monitoring how much fluid is coming out of those drains. Is the drain in place? Is the drain getting infected? When to clamp it, like if it's a T-tube, like do we clamp it for a couple hours after they've eaten so the bile can get to the food and start breaking it down if they're having like a cholecystectomy or something like that. So that, I think that's really kind of about it. It's that's about it. So it's kind of simple. I think that I've told you everything. I told you the wound complications. I told you about wound complications. Dehiscence, hematomas at the site, bleeding at the site. And there's a difference between an immediate wound problem and a in a late phase. So in the early phases of wound healing, that's like when they're still in the hospital, you're going to worry about dehiscence and opening, and it's really not until 48 to 36 hours that you're really going to start worrying about infection, things like that. So I think that is all that you needed to know. It's really straightforward, and we've talked a lot about this throughout the course of this semester. If you do have a problem with your patient following post-op or even in the intra-op, if that patient starts bleeding, it is essential that you figure out the cause of that bleeding and try to get it to stop quickly. I think we talked about this recently in class. And if you can, you put pressure on it, increase fluids, call the surgeon. So, and that's it. That is your perioperative experience in a nutshell. Thanks. You just shut it off.